Hello, this is going to be a presentation for Neuro Part 2. I'm just going to start with it right away and get into schizophrenia. So schizophrenia is probably one of the more commonly known psych disorders. It can take a prolonged period to diagnose due to the slow advent of symptoms and can technically start at any time well in someone's 30s. Basically with schizophrenia, they're going to have both positive and negative symptoms. Positive symptoms basically is going to be the addition of something that's not normally there. Hallucinations, some sort of verbal or physical tics, or a negative symptom, that's going to be something that's going to be missing. It's going to make the lack of muscle control, things like that. So it's going to be either be positive, it's going to be an addition, or a negative symptom. So we treat this by giving antipsychotics. So there's two types of antipsychotics. There's typical, which is your first generation, and your atypical. So your typical or conventional, as it's sometimes called, is Haldol and Thorazine. Both typical and atypical generally have the same side effects, but the atypical, because it's second generation, are going to have less side effects than the typical. So when we learn about different classic generations of medications, generally speaking, as the generations get newer, the side effects get less decreased. So schizophrenia is generally going to be caused from an increase of dopamine. Remember when I had the presentation last week that I had posted, we were going through Parkinson's. Parkinson's was due to a decrease of dopamine. When you're increasing dopamine, you can have someone patient with hallucinations. You basically end up causing a drug-induced schizophrenia. So in this case, we're going to want to try to block the dopamine receptors and also block some of the acetylcholine and norepinephrine and then histamine receptors also, because all these neurotransmitters are highly elevated, so we want to try to block them to control their symptoms. So there's quite a few side effects we're going to see. We're going to see that EPS again. EPS is something we had talked about last week in Parkinson's, and I'll go through that again in a second. But you're also going to see some hypotension and anticholinergic side effects. So as we're blocking the acetylcholine neurotransmitters, we're going to end up causing the anticholinergic side effect. And also we're giving them basically a CNS depressant. So if any CNS depressant, you're going to suppress the CNS, you're going to depress their other vital signs also, hence the hypotension. Now Thorazine, both of them are going to have some sedation. So Thorazine, you're going to see a little more sedation with it. You're still going to have hypertension, it's going to have anticholinergic side effects, but you're going to see less of those EPS symptoms. So of the two typicals, Thorazine might be a little safer to give your patients. Better yet would be giving them an atypical antipsychotic. This is going to be clonazepam, Seroquel, Abilify. A lot of these are used for various other problems. Like Seroquel is going to be used a lot to help patients go to sleep because it is a CNS depressant. You suppress the CNS, they get sedated, they go to sleep. So these are going to have a lot better chance of controlling the schizophrenia without causing those EPS symptoms. So it's going to be better to use one of these atypical second generation medications than the typical. So a little more in the typical antipsychotic side effects. You're going to see that EPS, you'll see neuroleptic malignant syndrome. Neuroleptic malignant syndrome, which we'll get into a little bit, is primarily going to be a huge increase in their temperature, blood pressure, and it can be potentially life-threatening. And then the EPS, that they also get acute dystonia, akathisia. Akathisia is pretty much inner restlessness. The patient's going to feel just uneasy and need to move. Then tardive dyskinesia is the abnormal muscle movements. They can also lead to agranulocytosis, especially the Thorazine. Agranulocytosis is your white blood cells. So it's going to basically destroy your white blood cells, and if you don't have enough white blood cells, you're going to have an increased risk for infection. So let's get into that EPS a little more. So the first thing to remember about EPS is technically irreversible once it gets to a certain stage. This is why we want to assess our patients in real time and make sure they're not having these EPS symptoms. If they are, stops the medication, switches something else. So EPS is going to be dystonia, it's going to be severe muscle spasms, and akathisia, which I already said is the inner restlessness, and then tardive dyskinesia. Tardive dyskinesia is a lot of physical tics. It's going to be lip smacking, excessive blinking, chewing motions, lip smacking. They'll do like pillow rolling with their fingers, all sorts of random physical twitches and abnormal movements they don't have any control over. So last presentation we had talked about we can treat some EPS symptoms with Parkinson's, with cogentin or benzotropine. Same is going to be seen here. This is going to help control those symptoms from EPS. Some further, just kind of, the next slide is a little bit more review on the antipsychotics. So again, EPS is going to be a big one for all of them. Agranulocytosis, decreased white blood cell count. So white blood cell count less than what you consider 4 on your count, or less than, so white blood cells should be above 4,000, or generally if you see this number is going to be 4. It's how it's labeled. But in this case, it's actually 4,000. So anything below that is going to be a warning sign for a patient. They're going to have decreased white blood cells, increased risk for infection. And then was the first sign of infection? It's going to be the first sign of infection is going to be fever. So one of the things to be aware of is they're going to have an increased risk for seizure activity, especially if they already have epilepsy. And then also they need to have cardiac monitoring. Because what happens is it's a prolonged QT interval. I can explain this better in class by showing you an EKG and how it's drawn. Basically, for our intents and purposes, a prolonged QT interval is the amount of time it takes for your heart's ventricles to polarize, to contract, and then repolarize. So if it takes a longer time for it to happen, there's a lot higher chance of the heart trying to have a beat in that period when it's repolarizing. And if that happens, it can't, of course, contract if it's not repolarized. Then it leads into VFib arrest and then potentially die. It can also lead to a lot of endocrine problems. Basically, it's going to lead to more commonly weight gain. It can also lead to an increase in your triglycerides. So you want to be aware of teaching them on their diet. Next is going to be depression. So depression, chronic depression is going to be seen for longer than 6 month period. That, you know, everyone can have acute depression. Someone's loved one passed away, a family member or a pet. That's going to be an acute depression. You get depressed for a short period of time, but eventually you're going to hopefully get over it and move on. If you have a chronic depression, that's when you might have something wrong with the neurotransmitters that's leading to that depression. So antidepressants, generally what they're going to, the best way to describe them are basically kind of giving patients uppers. So it's going to increase the neurotransmitters in their brain to get their brain back at a baseline balance. So the first one we're going to talk about is SSRIs, selective serotonin reuptake inhibitors. This is going to be the most common antidepressant out there because it's generally one of the strongest acting and quote-unquote safest ones you can give. So this is going to be your sertraline, Zoloft, Prozac, or Celexa. So some of the side effects with this is going to be your usual nausea, drowsiness. It can also lead to constipation, and also some of the bigger side effects, not so much bigger side effects, but the most ones you might be aware of is going to be sexual dysfunction and weight gain. This is going to be a huge complication with compliance. All antidepressant medications take several weeks, if not months, to have an effect. It takes time for those neurotransmitters up to normal. So if this is happening and patients gaining weight and having sexual dysfunction, they're not going to be inclined to continue taking the medication, so they're going to stop. And with all antidepressants, you want to continually monitor for a risk of suicide with the depression, because they're already depressed. You can actually cause too much increase in neurotransmitters that cause the hallucinations and delusions, kind of what you see in schizophrenia. That's why they have that too many neurotransmitters. You can kind of amplify them from depression to another one. Another major side effect for SSRIs is serotonin syndrome. Serotonin syndrome is the best way to describe it. It's going to be a highly elevated blood pressure. Also, neurologic complications, extreme anxiety, manic-like symptoms, confusion, hallucinations, sweating, fever, agitation, to the point where they basically have muscle tremors and go into a coma. So generally speaking, the serotonin syndrome can happen at any time when they're taking it, but most often it's going to be when they have taken it, either they've doubled their dose, which they should never do, or when they first start taking the medication, they're hypersensitive to it. All antidepressants should not be given during pregnancy because the fetus has the growing brain cerebral tissue, and if you have an increase in those neurotransmitters, you're going to basically affect the neurotransmitters inside the fetal cerebral brain and how it's growing. So you want to avoid all antidepressants during pregnancy. So SSRIs are going to have a lot of drug-to-drug interactions. One of the main ones is going to be MAOIs, which is another antidepressant, and we'll get into that in a little bit. Also, an important one is going to be for an herbal remedy, St. John's wort, which is an over-the-counter herbal remedy for depression. We're going to get into that with MAOIs also. We also want to be aware of any NSAIDs or anticoagulants, because SSRIs can suppress platelet aggregation, which is the ability of platelets to adhere together, and platelets need to adhere together to form clots. So you have an increased risk for bleeding. NSAIDs and anticoagulants also have an increased risk for bleeding, so we want to avoid those. Next one is serotonin norepinephrine reuptake inhibitors. Basically, it kind of works as the SSRIs, but you're blocking serotonin and norepinephrine for the kind of going to potentially see the same result, increasing your neurotransmitters, and then basically leading to a back to your baseline where you should be and hopefully resolve your depression. Same kind of side effects as SSRIs because we're affecting the serotonin. So again, you have serotonin syndrome, that increased blood pressure, you want to be aware of that. It can also lead to hepatic damage. So whenever you hear hepatic damage, remember your ALT and AST for your liver enzymes. Risk for bleeding along with that also. And again, another huge risk for compliance with sexual dysfunction and weight gain with these. So the next class we're going to get into is TCAs, tricyclic antidepressants. This one is amitriptyline or Elavil. This is an older medication class. It's not generally used too often anymore. This is largely because it has an increased risk for suicide with it, and it's highly toxic. So you only want to give a 2-week dose at a time. Anything above a 2-week dose can be toxic levels for the patient. So if you're giving a patient a medication that can potentially lead to an increased risk for suicide, and you're giving them a toxic medication, you're kind of just making the perfect storm for disaster. So with this TCAs, you are going to end up causing some anticholinergic side effects with this. So anticholinergic side effects are your constipation, your weight gain, your decreased metabolism, hypotension, bradycardia, vision complications. And with those anticholinergic complications, you're decreasing the heart rate and bradycardia. You can end up leading to some cardiac dysrhythmias, kind of slowing down the heart too much. And so you're going to want to get frequent EKGs and make sure everything's going okay with their heart and not affecting the conduction. Next is MAOIs. I'm not going to try to pronounce that because I'm already slurring my words. So the main one is Nardo. MAOIs they have some very unique interactions with medications and with certain types of food. They interact with something called tyramine. If you look in your 9th edition textbook, box 10.5 has the entire list. The couple slides from here is a list too. Basically, anything with tyramine is going to be in an aged or processed food or drink. So what is aged or processed? Generally, it's going to be your cheeses, meats, lunch meats, deli meats, your sausages. Also, it's going to be your beer, wine, alcohol, and spirits, because all those are aged and distilled. Chocolate, coffee, a lot of things with caffeine are going to be high in tyramine. So basically, anything that patients, especially here in Wisconsin, are going to want to eat, they can't have because of high tyramine levels. The increase in tyramine is going to potentially lead to an exacerbation of potential of a hypertensive crisis, which is pretty self-explanatory. It's a huge spike in their blood pressure. Same kind of like with the SSRIs and the serotonin syndrome, huge spike in their blood pressure. You can also see liver failure again. Can also end up causing severe hyponatremia, so decreased sodium levels. And your sodium levels should be between 135 and 145. Anything below that is going to be life-threatening. So the hypertensive crisis, as I kind of said, this is primarily going to be either because they've taken too much of the medication or they've taken an SSRI, they've had a combination of both. And it just leads to a huge increase in the blood pressure to the point where they can probably have an occipital headache, which is the frontal part of your brain. Basically, it's just that huge blood pressure spike just causes the compression in your brain, causes an extreme headache, and it potentially is going to lead to a heart attack. As I talked about with the SSRIs, the one thing you want to be aware of with your SSRIs is your patient taking St. John's wort, because St. John's wort works as a weak MAOI. So it's the same drug class. So with St. John's wort, you also want to teach your patient about the tyramines. They probably won't be aware of it. I think it's a remedy. I think it might be safer than, conventional Western medicine or Eastern medicine. But that St. John's wort, it's going to be important that you don't take that with any other medication, especially other antidepressants, because it's kind of that synergistic effect. Slide 20 is basically the entirely huge list of all the drugs and food you can't eat while on an MAOI. Like I said, primarily it's going to be your aged or processed foods, cheeses, or alcohols, and things with caffeine in it. Next is on slide 21 is just kind of an overview of some important facts for all of these medications. It is important to be aware of that all of these medications need to taper off slowly. You just don't want to stop abruptly. Because when you're artificially raising your neurotransmitters and you take it away, you potentially lead to further complications. The only medication that does not need to be tapered off is Prozac. Prozac is one of the SSRIs. It does not need to be tapered due to the fact that it has a very long half-life. And that long half-life basically means that your body's going to slowly metabolize it. So it's kind of like it's going to taper itself down just in its own metabolism. Next is some atypical antidepressants, kind of like your second generation antidepressants. As I kind of said, these are generally going to be safer than your conventional ones. So one I really want to point out, the other three are important, but the main one is going to be Wellbutrin. Wellbutrin is a very good antidepressant because it works well. Also, it can be used to help treat smoking cessation if they want to quit smoking. But for the most part, comparatively, it's going to be safer with less common adverse effects than the rest. You can still potentially have an increase in suicidal ideation, the increase in their blood pressure, increased seizure activity, but it's a lot less chance of these things happening than the rest. also doesn't really lead to the weight gain or the sexual dysfunction, and so you're going to have a higher chance of compliance if they have a more mild case of depression. Next is going to be bipolar disorder. So bipolar disorder is where someone's going to have manic highs and manic lows, and it can happen over months, minutes, hours. It kind of depends on each person's a little differently. So the main drug of choice for bipolar is lithium. Lithium, again, will take some time to have an effect. So what is it going to do? It's basically going to help stabilize the patient's neurological state of being and hopefully get them into more more control of their life. The best part is it does not cause depression, does not cause sedation or any euphoria. So it kind of completely stabilizes them out without causing any sort of abnormalities. The problem is a very narrow therapeutic range. And that is a number I'm going to want you to be aware of. Generally, for your textbook, listed at 0.8 to 1. What I want you to be aware of, just kind of make it a little easier for you, is any drug level above 1.5 is going to be toxic. So that's going to be your go-to for lithium. If it's above 1.5, it's toxic. Don't give them any more. So the problem with lithium is it's a salt. So it's a lithium salt. So our kidneys do what? Our kidneys excrete salt because water follows salts. We usually excrete sodium chloride, a sodium salt, but when we're on lithium, we can potentially cause complications by causing them to, it can lead to something called diabetes insipidus, which is basically an increased urination. An increased urination is going to basically cause them to excrete more of the sodium, and then what can happen is what you can get is going to be hyponatremia. Basically, your body's going to be expelling so much urine, you're going to lose a lot of salt. But what the problem with losing too much salt is your body wants to retain some salt. So it's not going to be able, your kidneys can't differentiate between a lithium salt and sodium chloride salt. So it's going to, the more your patient has to urinate, that polyuria, they're going to be retaining more of that lithium. So it's a lot higher chance of becoming toxic. So you want to limit them and how much water they can take. You don't want to give them too much water intake, so you give them excessive urination. You want to maintain how much sodium they're taking in for the same reasons. It's going to lead to polydipsia, which is basically increased thirst. That increased thirst is going to lead them to drink more, urinate more, higher chance of urinating out more of the sodium chloride, retaining the lithium salt. So it's very important you're minding their I's and O's to make sure that they're not urinating too much for the complication, for the potential of increasing their lithium levels. Other complications that can lead to is leukocytosis, so decreased white blood cells. So with that, you're going to be, again, risk for infection. And it was first signs of infection. It's going to be fever. Can also lead to hypothyroidism. We'll get into more on hypothyroidism later on in the semester, but for your thyroid levels, you want to be aware of your TSH, T3, and T4 levels. So it could be if they are abnormal. It can also lead to, of course, kidney nephrotoxicity if you're doing potential damage to the kidneys by causing this excess urination, things like that. Can lead to those complications. You also want to avoid diuretics in a patient with lithium. And with diuretics and ACE inhibitors, which is in cardiac, is both ACE inhibitors and diuretics are going to lead to an increased urination and decreased depletion of your sodium, which is then going to cause you to retain more of your lithium. So it's going to be a lot higher chance of lithium toxicity. Next is going to be anti-anxiety medications. Anti-anxiety medications are going to be ones that we've pretty much already covered before. And that's going to be benzodiazepines. We already covered benzos last week. Again, it's important identifier for benzos. They all end in LAM or PAM, so a quick identifier. The main thing with those is going to be that CNS depression, and then respiratory depression, so beware of the respiratory status. And then also, again, your antidote for benzodiazepines, which is the flumazenil or romazican. So quick little review on that one. Otherwise, you can use SSRIs, SNRIs. All these medications we already kind of covered can be used for multiple things. Another one, if they have mild anxiety, they can use something called Buspar or Busporin. Buspar is going to be a good anti-anxiety medication because it doesn't have a lot of serious side effects, but it takes time to have an effect like your antidepressants. Whereas the benzos, someone's having an anxiety attack, they can take a benzo and have results fairly quickly. Buspar is going to be good for acute anxiety, it'll be better for chronic anxiety and help control it in the long term. Otherwise, there's not a whole lot of side effects with that one. Otherwise, you can get into sleep disorders. Sleep disorders, again, what do you think you're probably going to use for these? I'm going to potentially use benzodiazepines, again, because it causes that CNS depression, causes that sedation complications. Or we can also use antihistamines, which is Benadryl. Benadryl is probably more often used to help people sleep than it is to probably actually treat allergic reactions. Kind of going through these a little quickly here. But basically, because we already covered benzos, it's all going to be the same drug class, even though it's different. The other things that can help patients with sleep disorder are benzoagonists, so they act like benzodiazepines. This is going to be your Ambien and Lunesta. Basically, with these, there are some certain complications you want to be aware of. You can have an increased risk for seizure with these. Benzos are used to treat seizures, but the benzoagonists can potentially cause an increased seizure activity. But generally, it's going to be a little less than just actual benzos. Next is they can also lead to bad birth defects in patients. So both of these have lower categories with their pregnancy risk. So you want to try to avoid them. And if you're giving someone a sleep aid, you generally want to give it at night, and it may end up leading to some increased daytime sleepiness, basically increased sedation throughout the day. So slide 31 kind of shows the same kind of review that we've kind of gone over a little bit with your benzoagonist. It's your Ambien, basically can lead to that lightheadedness, that daytime sleepiness. It's going to be a little safer on the patient than just benzos. Or you can give your patients a melatonin agonist. Melatonin is basically the neurotransmitter your body secretes that makes you tired. You can actually either just take melatonin over the counter, but it only truly works in like a third of the patients. Most patients take melatonin, doesn't really have much effect, but it is a natural way to try and help. Or you can take Romultin. Romultin basically is a melatonin agonist, so it works the same way as the melatonin. But there is some stronger adverse effects with it. It can lead to birth defects, and with birth defects it can also lead to pregnancy complications and post-pregnancy affect a woman's lactation. It can also lead to depression and then exacerbations of COPD by slowing down patients' respiratory tracts. Next, we're going to finish it out with CNS stimulants. CNS stimulants are actually going to be used for ADHD, attention deficit hyperactivity disorder. Basically, unlike common thought, ADHD, what's happening is their brain isn't firing fast enough, so they can't focus. Because if their brain's not firing fast enough, they lose focus because their brain kind of fires a little bit, and then it just slows down. And then when it slows down, patients like, I forgot what's going on. I'm not going to pay attention. And so it goes on. So to treat ADHD, we don't give what people always assuming patients with ADHD, we give them downers. We actually give them uppers. We give them stimulants. We're going to stimulate their brain so they can actually get their brain working at an appropriate pace so they can focus on the task at hand. Most times patients, like little Timmy took Ritalin, and now he's like spaced out and the planet. Well, basically he's actually looks weird for him because he's focusing on the task at hand versus just being all around all over the place. But a lot of things when you give someone a CNS stimulant is you're going to stimulate everything else in the body also, kind of like when things can cause CNS depression or sedation. You're basically going to kick in their fight or flight response into overdrive and potentially cause a lot of anticholinergic side effects. So this is going to be your Ritalin and your Adderall. Those are going to be your main ones. So the main complications you're going to be aware of is going to be cardiovascular complications because you're kicking that fight or flight response. So it can lead to some increased blood pressure, increased heart rate. You're going to see complications with insomnia because you have increased CNS stimulation and patients wanting to go to sleep. So if your patients have a history of CHF, hypertension, AFib, you're going to want to avoid these medications. You're also going to lead to that CNS stimulation, which can lead to hallucinations, delusions, and it can actually lead to drug tolerance and then potential dependence. It also has a risk for abuse because if you are a normal person and you take CNS stimulant, it's going to be like taking an upper, so it's going to give you that artificial high. So you're going to want to avoid other medications that can potentially lead to the same similar side effects. So for instance, MAOIs, SSRIs, they both can lead to hypertensive crisis. So it's going to stimulate your blood pressure and your hypertension, so you want to avoid it. You want to avoid caffeine and things like that, because caffeine is another CNS stimulant. And you're also going to want to monitor their weight, because it's going to kick in that fight or flight response. It's going to kind of kick in their metabolism, so they can actually lead to some weight loss and an anorexia. So this has kind of been a quick overview. We will review this more and better in class. Thank you.